Hey everyone, my name is Dr. Galatia Strong. I got 100% on my NPTE and this led me to co-found SPT with Me, which is an NPTE prep platform. If you enjoy this lecture, check out our other ones at sptwithme.com when you're studying for the NPTE. Now on to what you're actually here for, let's talk about the FIST, the Function in Sitting Test. The purpose of the Function in Sitting Test is to assess sitting balance. Now we're going to go into more detail about the test, what it includes in the following slides, but just keep in mind what's said on this slide. Now when you look through the assessment, you'll notice that the type of sitting balance that it tests is static balance, anticipatory balance, and reactive balance. Additionally, it's also going to test a person's ability to balance within their base of support. It's going to test their balance outside of their base of support. You know, they're going to have to lean forward, move side to side, things like that. So let's go through the test and make it easy. Before we do a deep dive into this functional outcome measure, keep in mind that anytime you learn about any functional outcome measure, you have to get the general gist of what the test is examining first. So obviously, as stated before, this is a sitting balance test. However, just knowing this alone really doesn't tell us about how intense of a balance test it really is going to be. So for example, there are a lot of things that you can do in sitting. You can test transfers when you're sitting. You can work on the ability to catch a ball while you're sitting. You could also just be sitting up statically. So let's look into what specifically the FIST outcome measure does look into. So gold standard assessment of this test is going to have the person at the edge of the bed with half their femur on, half their femur off the bed. Their feet are planted on the floor and they're able to maintain a sitting position. Now realistically, think about this. Does this test absolutely have to be applied at the edge of the bed? Now for me, I would say not necessarily. You know, what if this person is in a wheelchair? Couldn't you just have them remove their foot plates and just situate themselves in the same manner of having half their femur on, half their femur off, feet on the floor? I mean, of course, you know, armrests could get in the way since we're going to be moving a little bit in this test, but couldn't you just take it off, right? So just some food for thought. Of course, there's a gold standard for a reason. However, there are different ways that you can implement the test. So if we look at the test items, the first three, the nudges, these assess the ability to react to a spontaneous nudge applied from the therapist in different directions. So essentially, your patient is not going to be told when they will be shoved a little bit from the side, the front, or the back. So this can happen at any point throughout the test. So think about what type of reaction this is testing. It's reactive balance. Then there's also sitting, static sitting with eyes open, static sitting with eyes closed, static sitting while you shake your head left and right like you're saying no. All three of these are testing static sitting. You aren't moving your base of support, you aren't moving your center of mass. Next, we have sitting still, but the patient is lifting one foot up. So now you don't have your base of support as before. You know, both feet were on the floor, but now you have one foot up. So in this case, you're testing their ability to weight shift onto the leg that is still on the floor, along with weight shifting onto that respective ischial tuberosity. So here we are addressing their ability to change or alter their base of support, anticipatory balance. Next, we have picking up an object from behind, reaching forward, reaching to the side, then picking up an object from the floor. So here you're displacing your center of mass over your base of support in different directions. Still a way of testing anticipatory balance. Lastly, we have posterior, anterior, and lateral scooting. Our base of support is shifted once again. Anticipatory balance. Does this person have trunk control to move themselves without using their hand? Or if they do need to use their upper extremity, can they do it independently, or do they need some assistance? Now let's look at scoring. It's a 0 to 4 scale, with 0 being the most dependent, 4 being the most independent. Sitting balance is a great way to test trunk control. This is because your feet and your legs are pretty much still and they really don't play too major of a role depending on at least how you're sitting, right? Whether you're shifted forward or backwards, things like that. If you can do movements without compensating from moving your upper extremity to counterbalance, right? So you weight shift onto one side, but you can't balance, so you need your opposite extremity, upper extremity to help you out, counterbalance. If you don't need to do that, then you have pretty good trunk control. But if you do need to use your arms in this way, again, for the purpose of counterbalance, then your trunk is not as strong or as coordinated. If you need assistance with movements, even as you move your arms, then you are even more dependent. So it's a normal scale rating of how much assistance a person might need. So this test is specifically out of 56. That's the total number that a person could potentially get. 56 out of 56 is 100%. If you get 100%, that means you aced it, right? But if a person aces this test, that means this person was not necessarily appropriate to use this outcome measure. You know, it doesn't show any impairments. So use a different outcome measure for this kind of patient where you think they'll completely excel in it. Because remember, the ceiling effect, we actually want to help a person. There's no help that can be determined if you can't find any impairments. Now, as we went through all of these tests, individual tests, did you see any that required the person to stand up? No, they're all sitting. Did you see any tasks that required the person to change position, to go into something like supine or sideline? No. So anytime that you're going through test items of a functional outcome measure test, you really need to think for yourself and ask, you know, who would this test be appropriate for? And that's what we're going to go through next. Now, who's this test used for? Well, the ones that are listed on this slide, these are the ones that have been suggested for it to be appropriate for. However, consider this. Are these the only populations that you can use it for? I'm going to say absolutely not. Right? Consider someone who maybe has general deconditioning and over the years they have just really lost their ability to use this trunk. Implementing the fist could really be a great test for them. Furthermore, does the suggestion that these three populations mean that every person who has had a stroke or a TBI or vestibular involvement mean that you absolutely have to assess them with the fist? No. You know, if someone has had a stroke and they can walk, they're pretty independent in sitting from what you could tell, this would be a terrible test to implement. The purpose of any functional outcome measure is to utilize it to, number one, show that the person has impairments and to be able to keep them on for physical therapy, but also to help you understand what impairments to work on. Again, this test helps you see sitting balance impairments in static positions, during anticipatory movements, and with reactive movements. If there is an impairment, consider what direction did it occur in? Was it in the sagittal plane, frontal plane, transverse plane? When you have them close your eyes, this shows how much of an influence their visual system assists with their balance. If it's impaired, does that mean the vestibular system is impaired? Is that something you can work on? Now, as mentioned before, if someone is too high level for this test, you might just be wasting your time by implementing this test. Think about the ceiling effect. If you get 100% or your patient gets 100%, you aren't getting any information about how to help your patient since you couldn't find any impairments. If they get 100%, that means they did not have any impairments. Now let's talk about the opposite side of the spectrum, where the test is inappropriate because the patient is not high level enough to be able to utilize the results of this test effectively. So in this case, we're thinking about the floor effect. So let's say that a person needs max assist for literally all of these tests. Or let's say they're dependent, okay, with all of these tasks. So performing a test like this, again, is not helpful because ideally you want to find a test or a task that they can at least partially assist with. If someone can't assist with anything at all, how can you tell what to work on? You know, you have to find out the issue, right? Is it a vestibular issue? Is it because of proprioception? Is it because of the trunk strength in general? Is it coordination? Is it just the left side of the trunk? Any and all of these reasons, and potentially more reasons, could really be the reason for their impairment. So the fact that we cannot really narrow down what the true impairment is why this test wouldn't be helpful for this particular person. Additionally, is it realistic that a person who is completely dependent with all these tasks that we would expect them to improve so significantly that they could make at least the minimal clinically important difference? So we're going to talk about that next. Interpretation of the results. You know, if you think about something like the Berg balance scale, it's a very well-known fact that if you get a score of anything below a 45 out of 56, this is going to suggest that a person is at a fall risk. In the case of the fist, we actually do not have a specific value like the Berg does that indicates any sort of fall risk or really just a risk of anything. However, what I would say though is that when you interpret the score, You can interpret this as a level of independence marker. If this person is having some difficulty with reaching forward or reaching to the side or getting something from behind them, this can help you justify that this person maybe needs a caretaker because they're going to lose their balance if they try to reach for an object that they dropped, or they don't have enough trunk control to be able to feed themselves if they were to have to reach forward for their food. Now, something that is looked into is the minimal clinically important difference, the MCID. This particular value, 6.5, I found on the Shirley Ryan Ability Lab website. It's a great website that you can use for almost probably, if not all, functional outcome measures that we use. I will leave the link and information at the end of the lecture. Now again, the number that I have here is 6.5. This number is specific for the fist if it's done for someone who has had a vestibular involvement. If someone has had a stroke and you're doing this test on them, this 6.5 is not used to help interpret whether or not therapy is truly helping them. Very specific to vestibular issue. Now, what the 6.5 is suggesting is that the difference between your baseline measurement of having done the test for the first time, then some sessions go by, some treatments go by, then you do the fist again to reevaluate. If this individual score is a score that is greater than 6.5 compared to the previous test or the first test, this is showing that the therapy that you are implementing is really working and that this person is getting better. If you want more research on particular values for those who have had a stroke or those who have had a TBI with respect to the MCID, again, I would take a look at the Shirley Ryan Ability Lab. The reason that I did not put all the values on are because, these are, again, values that are not as well known as the Berg Balance Scale, maybe. 45 out of 56 is pretty much known by every PT out there. That's a pretty concrete value suggesting fall risk. But a concrete value for the fist, honestly, it just doesn't exist. But at least we can utilize what is out there for the time being until maybe eventually we get a more definitive value. I hope the fist has been cleared up for you. Check out sptwithme.com when you're studying for the NPTE. This is the website if you want access to the Shirley Ryan Ability Lab. Super, super helpful website. I used it as a student. I used it definitely as a clinician. There's no way that we can remember all these numbers, so we have to have a resource to look into when we need to use it.